I'm Grant Blankenship, and this is the What You Need to Know Coronavirus series from GPB. Coronavirus is not affecting communities with an even hand. In Michigan, Louisiana, New York, there's solid evidence that African Americans are infected more often and are dying more frequently than in other communities. In Georgia, that's likely true, but for now, we only know that it's likely true because officials in Georgia haven't been keeping records that could prove it to be true. To help us understand more about this, I'm talking today with Dr. Joseph Hobbs, chair of the Department of Family Medicine at the Medical College of Georgia in Augusta. And among other things, Dr. Hobbs studies the intersection of racism and healthcare. And thank you for your time today, Dr. Hobbs.
Thank you.
All right. So, yeah, as I said, you've studied how disparities in healthcare flow from racism. Now, with coronavirus, we're talking a lot about these underlying conditions being dangerous for people when they're infected by the coronavirus. How are racism that leads to unequal healthcare access and these underlying conditions related to each other in the South?
I think that in a sense, um, what we're seeing here in the South is not a lot different than what we're seeing in parts of the North and the West Coast too as well. There's a big, huge gap between the chronic disease that African Americans have and other groups of color have when compared to the population in general. A lot of that is based upon socioeconomic factors. We know that common diseases that we see that are disproportionately present in the African American community and already creates worse outcomes when compared to the population as a whole. These are the very same conditions that, quite frankly, predict for poorer outcomes when people have the COVID-19 infection. Those are hypertension, diabetes, severe heart disease, severe renal failure, chronic obstructive pulmonary disease, and it goes on and on and on. The sorts of things that are very commonplace in the African American community because this is the disproportionate disease burden that they already bear.
Right. So, uh, something I've been keeping track of all these numbers, making pie charts. And when I look at Dougherty County, at the people who've died in Dougherty County, the state will tell you whether we know they had an underlying condition, whether they didn't have an underlying condition, and there's another part that says unknown. And Dougherty County is the only place in the state where the unknown section of that pie chart is larger than the other two, which to me suggests that there's a whole lot of people who are not only sick, just as you've described, but also maybe who just don't have any contact with the healthcare system, which seems to be like the next level of dysfunction in everything you just described.
Well, healthcare disparities have been with us. Even all efforts toward even looking at universal healthcare coverage and things of this nature has been something that we've grappled with because if the way that you get access to healthcare is based upon your ability to pay for it, that might sound like a good way to look at healthcare. The problem is that what people fail to recognize is that if there's a segment of my society that's out there in the workforce, out there in the schools, out there in the public, and if they are uniquely ill as well, eventually someone's going to pay the cost for that if they don't have access to healthcare. It's either going to be us paying for it when those people come in with acute urgencies. And so all of us are impacted by this, which tells us that the whole idea of racial healthcare disparities is not just an issue for the minority community. It's an issue for all of us because the health of America depends upon creating equity in access to healthcare services for everyone.
And as I said at the top of this conversation, Georgia really doesn't have a very good idea of exactly how disproportionately this disease is affecting Georgians. They're not keeping very good numbers on it. Like 63% of the people infected, we don't know whether they're white, black, or whatever. Why does that matter in the thick of a pandemic that we know this fact?
Well, it tells you where you need to put your resources. It tells you where you need to do testing, where you need to do case follow-up to try to find out where the individuals have been, who they've had contact with, and things like this, because it just tells you where you need to put those resources to begin to get a sense of where the infectious process is so that you can begin to work on containment. Not knowing that is very, very difficult place to start.
So yeah, I spotted last week too that the state started actually reporting some of these racial demographics when it comes to deaths and infections. In the meantime, I've been bodging together, census data of what proportions of Georgia counties are African American with just the raw infection rates, and you can see the correlation at the county level pretty easily without Georgia Department of Health's help. But I guess my question is that county level knowledge, just being able to go and say, yes, people in this county, which is predominantly African American, are more likely to be infected, is that enough knowledge to begin this sort of prioritization that you were talking about of resources during an epidemic response? Or do we need something more fine-grained and particulate to really be effective?
I think that we need something more refined because if you look at some of these counties, I would wonder whether or not the fact that they don't have a case or they have single digit cases is because you haven't looked.
Yeah.
And the point being is that what we need is that we need surveillance, not necessarily surveillance of the entire population, but enough surveillance for us to begin to get a sense of the incidence of people getting infected with this. Because I think if you're able to get that sort of information, make sure that you're getting the information based upon gender and ethnicity at the same time, you're going to have information that's going to tell you a lot more about where this disease is. And because even in those settings, if you have a lot of disease processes, and these people may not be symptomatic with the disease, they are potential carriers of the process as well. You got to be able to look at the population in a larger sense than that to be able to find where this disease is and then to contain the disease in that particular area. And therefore, if the disease is there, the risk of those persons having bad outcomes and even deaths are higher. And under those circumstances, you'd want to put your resources there if you had nothing else to guide you in where those resources would be best applied. As an event passes in the night and it becomes distant in our memory, as humans, we are prone to make the same error again. I would hope that something like this has burned itself in our consciousness to know that our new normal has to be something different. And the way that we look at health and disease has to be something that is looked at more universal, because your health affects me. My health affects you. And so therefore, it's going to be important for us to make sure that we create systems within our country that does not permit these sorts of disparities to exist, because these disparities can have impact on all of us from a health standpoint, from an economic standpoint. I mean, all of those things are out there. So my fear is that we'll forget.